Starting with our sickest patient. This is Miss Masina. She's in CBU room 2, 69-year-old female, past medical history of diastolic CHF, mechanical mitral valve and coumadine, COPD, oxygen dependent, and diabetic. She's our new admission. She came this morning with 3-day history of fever, chills, productive cough, pleuritic chest pain. She was hypoxic. SATs were on the low 80s on room air. Lungs were absolutely horrible. She had leukocytosis with left shift. Her pro-BNP around the 3,000. Chest X-ray showed right-sided opacity and bilateral pleural effusion. Our working diagnoses so far are community-acquired pneumonia, CHF exacerbation, and COPD exacerbation.
Okay, so what are we doing for her?
For her pneumonia, we are doing the usual workup: urine Legionella, pneumococcal antigen, influenza screening, sputum microbiology, blood cultures. She's for now covered with azithromycin and ceftriaxone. For the CHF exacerbation, we're doing IV diuretics with Lasix. She continued with all her cardiac meds, only withholding parameters for blood pressure and heart rate. Obviously, she had the strict eyes and nose and daily weights. For COPD, the basics. She's on IV Solumetrol, Duonefs around the clock, and also oxygen supplementation. For the diabetes, she's on the Levemir along with pre-meal and covered with a sliding scale. Her INR on admission was therapeutic, so she will get her home dose of coumadine, which is 5 milligrams.
Okay, so what should I be looking out for?
Right now, she's stable, heart rate is okay, blood pressure is okay, so, but still on 5 liters of nasal cannula, and her SATs on the lower 90s. So if she descends further, you should go and assess her. If she's crackly on exam, she may need another 20 IV of Lasix, and if she's wheezing, she may require an extra nebulization. If she doesn't improve at all, just get another X-ray, stat, call your resident, call ICU, because she may require BiPAP.
Should I try venti-mask first?
You could, I guess.
She's a retainer. While venti-mask will improve her oxygen saturations, it might drive her CO2 levels up. So it might be better if you try BiPAP, given that she has COPD.
Okay. Do you think she'll need intubation?
She's DNR, DNI.
Alright, so let me just recap. If she desaturates, I found in obesity check, I give her extra Lasix, extra dual net if she's bronchospastic. If does not improve, get chest X-ray, call ICU for BiPAP. Intubation is not an option due to cold status, is that correct?
Yeah, that's pretty much it. That's correct. Moving on. Red team? Yes, I'm following Mr. Bman. Is Mr. Bman okay? Is he stable? Okay. He wants a sleeping aid? Alright, listen, I'm in the middle of the sign now, right now. I'll place the order, NIFO will take over after that, and they will be aware. Sounds fair? Okay, thank you so much.
What will I be aware of?
Oh, Mr. Bman, 503.
Oh, okay. The guy that urology was supposed to see?
Yes, correct, that one. Just to freshen your memory, 72-year-old male, nursing home resident, history of BPH, came 2 days ago with AKI secondary to obstructive uropathy. Foley was placed in the emergency department. They drained 2 liters of urine. His renal function so far is getting better. He's putting out good urine. Urology recommended avoiding trial tonight.
Okay, so I'll be watching out his out then.
Yes. So if they call you about him not putting out urine at all or less than 50 cc's per hour, do a bladder scan. If his residual are less than 200 cc's, that's okay, just watch him. But if they are over 200 cc's, you may replace the Foley.
Okay, so if low output, then bladder scan. If over 200 cc, then put Foley back.
Yeah, correct.
And he's a full code.
Yes, correct.
Who's next?
Norma Desmond, room 414, 89-year-old female, CMO. She's his patient.
You give a CMO patient to a student?
She wasn't CMO when I got her.
So I imagine that her impending death is all your fault.
No. Stanley, come here. That's your patient.
Okay. So, Ms. Desmond, she's an 89-year-old female. She's a resident from a nursing home. Her history is significant for advanced dementia, failure to thrive, and recurrent aspirations. She was sent to the ED because of abdominal pain, fever, and jaundice. So, her laboratory investigations showed an increased LFT as well as lipase, and her CAT scan showed a dilated common bile duct as well as distal stones. While in the emergency department, she was found to be hypotensive, so she got fluid boluses as well as IV Zosyn. She was then going to be transferred to the ICU, but she stabilized, somewhat tenuously. There was a discussion bedside, and they decided to make the goal of her care to be comfort, but this was after a good amount of protest.
Who protested it?
So, she's been declining for the past couple months now. She's essentially bedbound, barely verbal, and she's been in and out of the hospital frequently for these recurrent aspirations. Her healthcare proxy is Eve Harrington, and I put the phone numbers there for you in case you need to contact her. However, Eve has a brother and sister, and they were present at the meeting too. The family, they were presented with therapeutic options such as IR-guided gallbladder drainage. They spoke to the intensivist about the need for pressors, intubation, and that whole route. The healthcare proxy felt that these were just heroic measures, but the brother and sister, they didn't agree, and they wanted to give their mother a fighting chance. They brought up how the healthcare proxy wanted to put down the mother because she had refused a peg tube for her in the past. It was just really an ugly scene, but ultimately, Eve being the healthcare proxy, she was able to make the decision, but the others said they weren't going to let this go easily.
So they may call you. And just to warn you, they were trying to get me on their side to say that she can be saved. We already explained them that even if she survives, her quality of life is non-existent. They are not ready to listen yet.
I won't have any more bright ideas. How's she doing now?
So right now she's on sublingual morphine, she's on Ativan, scopolamine, everything for CMO protocol. We don't expect her to survive the night, to be honest with you.
Okay.
But you may have to pronounce her, and you may have to call, obviously, the family or at least the healthcare proxy.
All right.
Okay.
Is Bogart 216 the last one? Wasn't he supposed to leave?
So, yes. He's going to rehab. The paperwork is done. Transfer summary is done. Discharge order is already in. He's going with all his previous medications. The only thing that we did is that we cut Lopressor to half. Now his dose will be 12.5 twice a day.
Sounds good.
Have a good night. Good luck.
All right, thank you.
So, starting with our sickest patient.
Walking out for love. I'm walking out really down in a cool breeze. I'm gonna be late again. Driver, wait for me, please. I'm running all in vain, trying to catch this train. Time don't fool me no more. Throw my watch to the floor, it's gone crazy. Time don't do it again. Now I'm stressed and strained. Anger and pain in the subway train.
Action.
Just have any masters?
You cool, I guess.
Okay.
He's a retainer. Well,
Baby, can't you see?
We were